Hello students, today we'll discuss an interesting topic because all of you know inguinal hernia very well, direct, indirect, then one side, unilateral, bilateral, bibinocil, incomplete, complete, Hasselbalch triangle, myofibrillar orifice of Fouchard, surgical anatomy. All these things are important, which you can always read my manual of surgery and clinical method in surgery, where it is given in detail. Now, recurrent inguinal hernia is another topic which is important because inguinal hernia, you do surgery, maybe mesh repair commonly or tissue repair, whatever. I'm not going to discuss what you are going to do. Laparoscopic, open mesh, and tissue repair. So these are the three types of repair which we do for inguinal hernia. Now, recurrence, when it occurs, it's called a recurrent inguinal hernia. Rather difficult to manage, an interesting topic, and surgeons, it's a challenging topic, challenging patient and challenging topic for a surgeon to deal, to make, prevent further second recurrence, first recurrence, second recurrence, third recurrence, fourth recurrence. Maybe rare 1%, less than 1%, but can occur because of certain reasons. So it is also a short note for UGs, main question for postgraduates, and clinically, previous scar is there, hernia is there is a recurrent inguinal hernia. So important to deal that, how to deal with that also. That we have got a live session, how to examine a recurrent inguinal hernia, and that session again, how to examine, how to go through such patients also, it is discussed very well. You can always go through my live session in the SRB Surgical Insight YouTube channel, which we had last week. You can learn how to examine such difficult, problematic recurrent inguinal hernia. So I'll discuss theoretical aspect and concepts basically, actually not exactly theory, concepts and newer classifications, how it is useful to treat such patients. That is recurrent inguinal hernia. That is a very, very important topic for surgeons of all type, general surgeons, specialty surgeons, whoever deals hernia, and for UGs for learning purpose also. So what is hernia? I'm just going to the what is hernia, then I'll discuss about the what is recurrent hernia. I'll just go through the slide, it may not detail much because it's the basic thing. So to bud, to protrude, to rupture, this is the meaning of hernia. So protrusion of the organ entirely or partly through its containing wall is a defect, and sac. Protrusion of the content is the eventual effect. Groin is inguinal femoral area. Inguinal hernia is the commonest, this is the point which you have to remember, commonest abdominal hernia. So indirect hernia is congenital one, direct is acquired. So all of you know that, but it's better to remember again, recap, remember, don't get confused, especially UGs. Can be unilateral, bilateral. With the two factors, important thing, weakness of the wall and raised intraabdominal pressure. Weakness of the wall, raised intraabdominal pressure. The two things which you have to remember always. I'm not going to detail, this is how the chief complaint comes. This is the history that you have to take, just go through this slide. Swelling, pain, aggravating healing factors, it's suggesting complications, vomiting, distension, constipation, pain severe, irreducibility, all those things are the suggestive complications. Previous history of hernia surgery, previous history of other surgeries, treatment for other diseases, family history, personal history, mainly smoking, pawn chewing, alcohol. This is the history, this slide important. And history relevant to present factors, respiratory, cough, tuberculosis, smoking, GI, constipation, habitual constipation, and other things. All these things are the important to, which say that it raises the intraabdominal pressure. It's the main important causative factor for developing, especially inguinal hernia, already told. Loss of appetite, sudden reduction in the weight weakens the abdominal wall muscles and groin muscles and cause of the hernia. And examination, I'm not going to examination, always do it in standing position and lying down position. Both is most important in the exam. You have to write it, you tend to forget it. Both sides should be examined, inguinal scrotal area. Here you can see the right side scar, you can see here, right side recurrent inguinal, you can see the hernia here, there is a scar here. So inspection, I'm not going to detail it. This table clearly tells what is the meaning. Expansile impulse on the cuffing. It's a momentary increase in the size so that it aparts, your finger get apart when you feel it, and you see it is expanding like this. Reducibility, gettable swelling, taxis, all these landmarks, pubic tubercle, most important thing. It is felt, not pubic could not, you can't inspect it. You can only palpate pubic tubercle. Remember, you can only palpate. And taxis, gettable swelling, Zeeman test. Most important test is deep ring occlusion test. Other tests also important. So opposite inguinal region, bulbar with the pupil skin, inguinal node examination, abdomen examination, and percussion standing, auscultation standing, abdominal for scar, muscle tone, Malgagni bulging. So it weakens, it shows that there is a weakening of the abdominal wall, mass, free fluid, all the things are the precipitating factors. Rectal exam is very, very important in hernia. In any abdomen disease, mass abdomen, abdominal disease, hernia, you have to write rectal examination, you have to do rectal examination for stricture, BPH in elderly males, and so on. The respiratory system is again precipitating factor for any altered breath sounds, effusion, and so on. You have to look for. Spine is again important point. So remember different classifications, clinical classification, reducible, obstructed, strangulated, inflamed, incarcerate, occult. No swelling, but pain is there, typical in the groin, inguinal region. Gilbert classification, 1, 2, 3 is the indirect, 4 is the direct. 1 is 1 finger, 2 is the 2 finger, 3 is the 1 is just snugly finger reaches there, not doesn't go. 1, 2 is 1 finger, 3 is the 2 finger, and 2 finger or more. 4 is the direct, 5 is the direct functional defect, 6th is the mental one, 7th is the femoral. This is the Gilbert classification. You have to remember that. Now currently European EHS classification is the most important. This is what exactly shown here very clearly. I'm not going to detail it, but it's easy to remember, but important. And surgical, remember surgical anatomy of the inguinal canal, difference between indirect and direct inguinal hernia. Indirect is piriform, obliquely placed, or lateral to the inferior epigastric artery, and it's got a typical fundus body, neck. Neck is narrow, whereas direct is neck is wider, it is medial to the inferior epigastric, it is a globular, it comes through the posterior surface of the inguinal canal, posterior wall of the inguinal canal. So different enterosil and amuntocil, enterosil contains bowel, it is resonant, gargling sound is there, initial part is difficult to reduce, later part is easier, whereas opposite of that, amuntocil is the granular, no gargling side, it is dull on percussion, and the later part is difficult to reduce. Differential diagnosis for groin swelling. Groin is inguinofemoral region. Complication of inguinal hernia, complication of surgery. Remember all these things may be asked in MCQ. Ritus hernia, sliding, pantaloon hernia, Madel's hernia. Sliding hernia, posterior wall is formed by the bowel, commonly left side, sigmoid colon, and urinary bladder. Posterior wall is formed by the sigmoid colon, difficult to dissect, may injure it. So exam standing, expansion coughing, reducibility, gettable swelling, deep ring occlusion test, rectal exam system. These are the important thing you have to remember. So all these things I'm not going to detail. Bilateral hernia, gettable swelling, impulse on coughing, funicular type. So Siemens test how to do. Ring occlusion test is very important, remember. So auscultation standing, percussion standing, bulbar urethra, and this is the femoral hernia below, inguinal hernia is above and medial to the pubic tubercle. Femoral hernia is below and lateral to the pubic tubercle. Anatomical location you should remove. Recurrent hernia, you can see the scar here, recurrent hernia. Large hernias often mimic hydrocele. So now we'll go to the, after basic about hernia for 5 minutes, then go through the recurrent inguinal hernia. Again, read my SRB manual surgery for detail about all hernia, inguinal hernia, femoral hernia, ventral hernia, intestinal hernia, and other rare hernias also. And my clinical method in surgery exactly gives how exactly you examine a patient with the hernia of all types. Recurrent inguinal hernia, what is the definition? Hernia recurrence in inguinal area after earlier inguinal hernia surgical procedure on the same side, either by tissue or mesh or by open or laparoscopic approach. So tissue repair or open mesh repair or laparoscopic mesh repair, whatever the type, if recurrence occur on the same site after surgery, that is called recurrent inguinal hernia. So incidence is 50% of more occurs in 5 years. When it occurs, within 5 years common, but it can occur as late as 25 years. Remember, it can occur, because after that, some precipitating precipitating factor develop. They can develop. In the first 2 years, it is 4%. For Liechtenstein's, 10% for laparoscopic. 10% laparoscopic, because first 2 years. After that, it is probably similar or variable. So it is still more common for laparoscopic approach, but reason is maybe skill and threading of the mesh may be not proper, not fixing the mesh. All this, so many reasons are there. Incomplete dissection also may be possible, or missing the sac as such. So there were 70% time recurrences, 25 second time recurrence. First time recurrence 70%, 25 second time, 4% third time, even fourth time recurrence can occur. Remember, all these things are the important thing which you have to remember. So recurrence, how many times recurrence common? This is the point which you have to remember. So causes for recurrence, obesity, age, all these things, age, remember TNF, tumor necrosis factor, decrease can cause, or rise in MMP, matrix metalloproteinases, alteration in the hyaluronic acid. Systemic factors I already told, chronic cough, respiratory problem, constipation, bowel problems, urological problems, all those things. Recent weight loss ability, I already discussed that. Type of work, strenuous work, weightlifting, gym, going to the gym, exercise, all those things also can cause. Local factors, tension over tissues repaired, size of hernia defect. If you put less size mesh, big defect, then problem. Emergency operation, where you can't, if there is a gangrene for previous hernia surgery, you will put only tissue repair, mesh won't be placed. Recurrence is high, infection recurrence is high, hematoma formation, seroma formation, and presence of precipitating factors which are not treated. BPH, urinary symptoms, chronic cough, smoking, and constipation, all those things if not treated. Interpatient fat and muscle, failure of incomplete removal of sac, thereby the pantaloon hernia, Romberg's hernia, both direct and indirect sac, they present as a direct hernia. Indirect sac is missed, not identified, not treated, then it will cause recurrence. Presence of hematoma, infection, nerve injury, all the things are the local factor. This is how exactly will classify causes for recurrence. And continued degeneration is important cause. Many times everything is fine, but still recurrence occurs. Large mesh, everything you have used all guidelines, you have used proper care, you have skill, everything. In spite of that, if there is this is probably one of the very quite common or not uncommon cause. Continued degeneration of the facial layers. I said that localized mesenchymal metabolic defect. Somewhere tissues go for degeneration. In spite of placing mesh, beyond the mesh margin, degeneration occurs. Some mesenchymal metabolic defect in that area causes recurrence. This is very difficult to manage in such patient. Very large mesh, entire area should be covered, like stopas, giant prosthesis, or laparoscopic large mesh placement. Such things have to be done, because here there is not problem in your skill or technique, problem in the tissue as such. Greater tension on the medial side. If this is the hernia, we have placed mesh here. So this is the area, medial aspect is very common site of recurrence, because tension is more, so burden is more, and intraabdominal pressure is more, burden occurs. So the medial aspect of the inguinal region close to the pubic tubercle, so recurrence is common in that area, medial. So medial recurrence is very common. And factors are modifiable factors, missing indirect sac, technical errors, mesh with improper mesh size selection, all these things are modified. You can correct it and correct it properly. Non-modifiable, age, collagen defects, long-standing lung disease, all the things are difficult to treat. They are not, cannot modify. It will occur, tend to happen. They are not in our hands. So the three major causes of recurrence are classified as omission of preoperative investigation and alleviation of pathological conditions which produce increased intraabdominal pressure. Like this is of the, if you don't treat BPH, just to treat mesh hernia without BPH treating, don't take care of the pulmonary system, don't treat the constipation, and then recurrence can occur. Errors in the operative management and technique. Selection of size of the mesh is difficult, mesh fixation is wrong, mesh migration can happen because of the improper fixation. So all these things are the errors, it can be rectified with the proper care, skill. Postoperative complication, infection, postoperative cough, postoperative respiratory problem, postoperative bronchitis, hematoma, seroma formation, mesh extrusion, mesh may not take up, mesh reaction can occur, mesh extrusion can occur. Such patient, postoperative, that can cause recurrence. These are the three major factors how is classified why recurrence can occur. So classification are different. In Nihel's classification, four. This is classification 4 is actually the recurrent one, Nihel's classification. But currently, recurrence of inguinal hernia after suture repair, mesh repair, the two repairs, Bethany's, Scholdi's are the suture repairs. So, Deserta, their suture repair, even though, of course, their prosthetic suture repairs, natural. So, tissue loosening, tissue laxity, TL it is called as, or tissue disruption. Tissue gets weakened or tissue gets disrupted, ruptures. your suture line disrupts. So the two reasons why recurrence can occur. So it is classified as a TLTD in case of suture tissue repair. TLTD, either weakening or disruption. Recurrence by open mesh repair classified as mesh distant, mesh is gone somewhere away. Paramesh, mesh adjacent to the mesh area get weakened. Mesh, complete mesh get migrated to other area, entire defect is opened and unclassifiable. So the three different classifications is commonly used now to classify and label it. Mesh distant, paramesh, mesh migration, unclassifiable. And again, in time phase of recurrent inguinal hernia was defined according to the duration of the primary open IHR to the recurrence. So when you do open inguinal hernia repair and when recurrence occurs, early E less than 2 years. Olden days they say early recurrence is 5 years, but it is not so. Currently it's 2 years is the guideline. And intermediate between the 2 to 20 years, less than 2 years, 2 to 20 years. 20. This is labeled as I. This is labeled as E. And more than 20 years, it's called L. So E, L, I, L. So if it is a tissue repair, TL, E. Or if it is mesh repair, MM, L. Like that it is being named and classified. TLI, TDL, MD, MML, and so on. Now the time for developing recurrent inguinal hernia was determined depending on the time when patient realized their recurrent inguinal bulging following the first surgery. So recurrent, again a newer classification, that is very important actually, based on the where exactly anatomically. Now this one is different. This is the classification based on when it happens, 2 to 5, 2 to 20 and more than 20, and why disruption occurs. It gives a pathological nature of the recurrence, this one. Time duration and pathological nature, this classification. Whereas this gives the classification anatomical location. That one is the pathological and time duration, early, intermediate, late. That this one is the anatomical location of the hernia. R1 is high oblique external, front it is, it's easier to treat. R2 is, I said, like a direct hernia, more, but all these are less than 2 centimeters in size. Both are less than 2 centimeters. The size is important. And one is R2 is medial posterior. R1 is lateral anterior over the external oblique. Lateral anterior, medial posterior. R1, R2. Now R3 is the most dangerous. Entire area, groin area is involved. There may be multiple defects. It will be inguinal eventration, it is called as often. Multi-recurrence hernias, non-reducible, contralateral primitive recurrent hernias, and many compromised aggravating factors, difficult to treat. Example, severe obesity and so on. And we not easily included in the R1, R2 after pure tissue repair or mesh repair. So R1, R2, R3. R1 in front, lateral, in simple identification, anatomical. This is the anatomical classification. And R2 is posterior, medial, close to the pubic tubercle. R3 is big one, larger big, involving entire area, multi-recurrent, 3 times, 4 times, big defect, femoral recurrences, everything comes as a R3, quite difficult to treat. You have to treat large mesh, giant prosthesis or laparoscopic, this one. So there is this classification is anatomical. EIL classification is time bound to 20 years, more than 20 years. And TLTD is for tissue repair, MM, MD, PM, all those things are for the pathologically how after mesh repair disease occurs. This is the anatomical one. So time duration, pathological nature wise, tissue repair versus mesh repair classification, and time duration R1, R2, R3. This is important to treat patient. So high external oblique near this R1. R1 is high external oblique in front. I already told you 40% common. So this is how exactly R1 occurs. Low direct above pubis medially. This is most common. Medial is the most common, I already told. Direct above pubis. This is R2. This is the area R2. And whole wall, entire wall, I said it's R3. Big area, groin area, irreducible complications and so on. This is the complete failure of the previous operation. This is complete failure of the previous operation. 10 to 13% R3, this one. This is R3 here. See, entire area is involved. Entire whole wall It's a complete failure of the previous surgery. So this is the typical recurrent high external low direct whole wall, entire wall, R3 it is called as. So this is important for treating the patient because R1 you have to treat under local or spinal open mesh repair or like a Gilbert mesh repair plugging, whereas R2 again open mesh repair or preperitoneal mesh repair. Once preperitoneal mesh repair is sufficient, whereas after pure recurrent again I already told classification again after pure tissue repair, maybe Bezani, Sholdi, Desarada, after open mesh repair, Lichtenstein's, after laparoscopic mesh tap and tap. This is how exactly classified because it is important. So what approach next you will use to treat the recurrent inguinal hernia as such. So again, size less than 2 centimeter height, more than makes lot of defect in lot of difference in understanding and treating the patient and further recurrence to prevent. So evaluation, I'm not going to detail history, clinical exam, evaluation, specific factors is important. The main cause for recurrence important. MRI of the groin gives a clear idea, not CT, not ultrasound will give the idea, but to have a very clear idea of the which tissues have disrupted, where is the mesh which already put there, how much defect is there, what type of, whether it is MM, PM, MD, and size is important, I already told. Size is important, I already told 2 centimeter, more than 2 centimeter location. So that is all assessed properly by the proper MRI. This is the choice investigation, imaging for recurrent inguinal hernia. Evaluation for surgery, of course, all the things are regularly there for surgical fitness. So treatment, R1 Gilbert mesh repair, simple anterior procedure, put a mesh under local or spinal, very easy, with a very good result. R2 is medial posterior, I have told, close to the pubic tubercle. Once preperitoneal, here you have to put the preperitoneal mesh repair, maybe LA or SCA, spinal anesthesia, local or spinal anesthesia. R3, you have to put once for unilateral, again, always you have to put a preperitoneal mesh repair, either through laparoscopy or open. In unilateral, once preperitoneal mesh repair is sufficient. Otherwise, you have to put a giant prosthesis, reinforcement of visceral sac, GPRVS or Stoppa's procedure, or ideally laparoscopic mesh repair under GA. Under GA, you have to use GA because extensive dissection is required. You have to put a very big mesh covering entire area, like a pelvis is, will be held, will be supporting, pelvis will be supporting with the mesh entire content or hernia, peritoneal area, lower part of the peritoneal area will be supported between the pelvis and the peritoneum by a large mesh. It will hold like this. This is called giant prosthesis. So that is the once unilateral, or if it is one side, it's called once. If the both side, called stoppa, or laparoscopy both side you can do. But proper dissection covering entire area where weakening is there should be done. This is for R3. So remember recurrent inguinal hernia definition and remember the classification. That gives very clear idea. Remember causes. I already given the body weight, age, local factors, other precipitating factors, and type of work, everything. And important thing is whether it is tissue repair, open mesh repair, laparoscopic. In the tissue, TL, tissue loosening, tissue disruption. And another thing is early, less than 2 years, intermediate 2 to 20, more than 20, late, EIL, that will include in the classification. And in the mesh repair, MM, mesh migration, mesh distant, and paramesh. That's the 3 types. And you can club all these things and give a classification figure for that classification type to that particular patient with the recurrent inguinal hernia. And R1, R2, R3 mainly anatomical classification. R1 anterior, lateral, in the external oblique near deep ring. R2 is posterior near the pubic tubercle. R3 is entire area. It's a complete failure actually. So R1 anterior Gilbert mesh repair, easier, local or spinal. R2 is always preperitoneal mesh repair, local or spinal one side. R3 is preperitoneal mesh repair, large mesh or giant prosthesis covering the both side, called Stoppa's procedure, or ideally laparoscopic mesh repair. So this is anatomical classification is very, very important for recurrent inguinal hernia. In spite of that, I already told I got a first recurrence, second recurrence, third recurrence, fourth recurrence can occur. Very, very difficult. Anatomy totally disrupted. You may injure cord, you may cut the cord, you may injure the vessels, iliac vessels, femoral vessels, because difficult to dissect. bleeding can occur, hematoma can occur. It may injure the bowel, either large bowel, small bowel, because it will be adherent there. So all precautions should be taken not to injure bowel, not to injure core structures, and not to injure major vessels, iliac vessels. The three things very, very important when you operate for recurrent inguinal hernia, so that safety complications you have to always consider. Of course, eventually mesh repair is the standard for recurrent inguinal hernia. There is no tissue repair when you treat recurrent inguinal hernia. Of course, this anatomic classification is most important to decide what type of approach, what type of procedure you are going to do. And of course, it's technically demanding. Always you have to pass a catheter, sometimes nasogastric tube, and patient has to be there in the hospitalized, especially in the R3 type. Even R1 or 2 in Western country, they do as a daycare surgery. For in our developing countries, few days admission, but long time admission may be required, especially to avoid infection. Asepsis is the most important thing in all these patients, because added sepsis in such patients is difficult to manage. Eventually, if recurrence occurs or infection occurs or mesh extrusion occurs. So that's what exactly recurrent inguinal hernia, RIH, very common topic for postgraduates. Very need to understand basic thing, at least for undergraduates, this newer classification as such. So students go through my clinical manual of surgery, current edition, for detail about hernia, my clinical methods of surgery, current edition, for exemption of hernia, operative surgery for different approaches for hernia. And as I request all students to subscribe my YouTube channel and share with their friends and colleagues and learn surgery day to day. We got around 500 lectures with the daily MCQs and live sessions already happening. Many live sessions already there. Different like hernia, students will present. Faculties other than me, senior faculty will be there for discussion for 1.5 hours. So how to present a case in the exam with the proper discussion will be there. So how to treat a case sheet also will be discussed there. So basic things. So go through earlier live session, join live session for learn surgery in a better way, both with video, lectures, all those things. Also, always have my manual of surgery, gives everything about the whole topic as per CBM syllabus, makes surgery interesting and understandable. Clinical method surgery gives a very clear idea how to examine a patient with a video of examining the patient in each topic. Again, request student to subscribe my YouTube channel. I hope you understood a different topic, difficult topic, that is recurrent inguinal hernia very well. Thank you so much.